Imagine a middle-aged man with a history of MI and angina and always carries nitroglycerin tablets with him. Like many men his age, he has also struggled with erectile dysfunction. And last night, he took sildenafil prescribed by a local doctor. Early the next morning, he develops chest pain and immediately takes a sublingual nitroglycerin tablet. And within minutes, he collapsed. His blood pressure is unrecordable, his pulse slows, and he is rushed to hospital. So what just happened here, and why did a life-saving drug like nitroglycerin suddenly become a life-threatening in this patient? The answer lies in the dangerous interaction between sildenafil and nitroglycerin. Welcome all. In this video, we are breaking down one of the most critical drug interactions you must know for your exam and for patient safety. By the end, you will understand the physiology, the danger, and the key takeaways. Sildenafil, which is also known as Viagra or Revatio, is a phosphodiesterase type 5 inhibitor. It is used in the case of erectile dysfunction. When there is sexual stimulation, there is a release of nitric oxide in the penis. Nitric oxide activates an enzyme called guanylyl cyclase, which produces a messenger called cyclic GMP. The cyclic GMP causes smooth muscle relaxation and vasodilation and leading to an erection. But the body has a built-in off switch. An enzyme called phosphodiesterase 5 breaks down cyclic GMP and ending the erection. Its onset of action is between 30 to 60 minutes. The peak action is reached at 60 minutes and the half-life is around 4 hours. But the functional vasodilatory effect remains for 8 to 12 hours. And now, organic nitrates, which include nitroglycerin, oral isosorbide dinitrate, or mononitrate. Nitroglycerin is most commonly used in patients with angina attack. In angina attack, the heart muscle is not getting enough blood supply because of narrow coronary vessels. When we give nitroglycerin, it causes relaxation and dilation of blood vessels. This reduces the workload on the heart and improves the blood flow to the coronary artery. As a result, oxygen supply and demand mismatch is corrected and the angina pain is relieved. And what is their mechanism of action? The nitrate drug itself is converted directly into nitric oxide in the body. This nitric oxide activates the guanylyl cyclase throughout the entire cardiovascular system. This leads to massive production of cyclic GMP, causing systemic vasodilation. Because of systemic vasodilation, the blood pressure drops. As blood pressure is the product of cardiac output and total peripheral resistance, if either falls, blood pressure comes down and the heart does not have to work hard. And what happens if we combine them? What happens if a patient takes sildenafil and then uses a nitrate? The nitrate floods the system with nitric oxide. This causes a huge surge in cyclic GMP production everywhere. As sildenafil is already on board, blocking the phosphodiesterase 5 enzyme that is supposed to break down all excess cyclic GMP. As a result, there is a catastrophic, unopposed buildup of cyclic GMP levels. This produces a profound, life-threatening hypotension, that is, severely low blood pressure. The blood vessels are so dilated that there is not enough pressure to pump blood to the brain, heart, and other vital organs. This can lead to syncope, that is fainting, shock, myocardial infarction, heart attack, and even death. According to the American College of Cardiology or American Heart Association, officially declared that giving nitrate with sildenafil is proven harmful, that it can produce a class 3 harm, and is supported by the highest level of evidence and must be strictly avoided in all patients. How long they must be separated? When managing patients who may require both phosphodiesterase 5 inhibitor and nitrate, the timing between the two drugs is critical to avoid life-threatening hypotension. The safe interval depends on the half-life of each phosphodiesterase 5 inhibitor. For example, in case of sildenafil, as sildenafil has a half-life of about 4 hours, nitrate should be avoided for at least 24 hours after the last dose of sildenafil, even though the drug is mostly cleared earlier. For vardenafil with a half-life of 5 hours, it carries the same recommendation: nitrate should not be given for at least 24 hours. Tadalafil stand out with a much longer half-life of about 17 hours. Because of prolonged action, nitrate must be avoided for a minimum of 48 hours after tadalafil use. In special cases, for example, a high dose or chronic sildenafil use, that is a dose of 20 milligrams 3 times daily for pulmonary artery hypertension, counts the same, that is 24-hour nitrate hold from the last dose of sildenafil. And sometimes cluster headaches are treated with a high dose of nitrate because nitrate can cause vasodilation and abort an attack. On the other hand, sildenafil have also been tried off-label for headache syndrome, including cluster headache. So even though both drugs may help independently, their combination is considered unsafe. And what should be the management options of acute chest pain in a patient who recently took phosphodiesterase 5 inhibitor? In this case, as nitrate are contraindicated if within the prohibited window, we can use the alternative anti-ischemic options. For example, we can use supplement oxygen if there is hypoxemia to improve myocardial oxygenation. We can use aspirin to act as antiplatelet to prevent clot progression. We can use morphine if pain persists, as the morphine act as analgesic and also relieve the anxiety. Beta blocker metoprolol if no contraindication like severe bradycardia, hypotension or heart failure. Calcium channel blockers, for example diltiazem or verapamil for vasospasm. And anticoagulants if there is acute coronary syndrome suspected. Definite treatment depends upon whether it is ST elevated or non-ST elevated MI. If there is life-threatening ischemia and nitrate appear unavoidable in this situation, place the patient in monitored setting, establish IV line, give them fluids, and start low-dose nitro infusion with real-time BP monitoring, and have vasopressor, for example phenylephrine or norepinephrine, ready. What if a patient accidentally combines them? There should be immediate assessment. Place the patient in a spine position, check BP, heart rate, ECG. If symptomatic hypotension persists, that is systolic BP is less than 90, then give IV isotonic crystalloid bolus, that is 500 to 1000 milliliters. Give IV phenylephrine or norepinephrine if refractory. And continue cardiac monitoring for ischemia and arrhythmia for 24 hours. There is no role for dialysis, as both of drug are highly protein bound and have a large volume of distribution. Common clinical scenarios and practical tips. AED patient with chest pain. Always ask about erectile dysfunction medications. Chronic nitrate users for angina must switch to ranolazine, beta blocker, or calcium channel blocker before prescribing phosphodiesterase 5 inhibitors. In case of pulmonary hypertension, the sildenafil plus nitroprusside sometimes used in ICU settings, but monitor cyclic GMP-mediated hypotension. Topical nitrate, that is nitro patch, are also contraindicated with sildenafil. Recap. Concomitant use causes synergistic cyclic GMP buildup, which can cause catastrophic hypotension and class 3 harm, so contraindication. For sildenafil or vardenafil, a 24-hour gap, and for tadalafil, a 40-hour gap is must before starting nitrates. For unavoidable angina within the window, pivot to non-nitrate anti-ischemic therapy and obtain specialist help. And that's all for nitrates versus sildenafil.